Vamos a comenzar con nuestra sexta reunión de educación médica continua de la Sociedad Chilena de Trastornos Bipolares. Esta noche contamos con la presencia virtual del Dr. Tomas Hayek. El Dr. Hayek es profesor de psiquiatría de la Universidad de Dalhousie en Nova Scotia, Canadá. Queremos recordarles que la Sociedad Chilena de Trastornos Bipolares está realizando un ciclo de psicoeducación para pacientes y familiares que ya ha cumplido con 5 sesiones y la próxima sesión será el sábado 22 de agosto a las 11 de la mañana y esta sesión será dada por el terapeuta ocupacional, señor Leonardo Estrada, quien va a hablar sobre el manejo del estigma a través de la participación ocupacional. Todas las sesiones anteriores del ciclo de psicoeducación, ustedes las pueden revisar en el sitio web de SOCHITAB y también en el sitio web del Círculo Polar. Abajo en la pantalla aparecen las dos direcciones, www.circulopolar.cl/esperanza y www.sochitab.cl pinchando el icono de YouTube. Queremos recordarles también que los días 9 y 10 de septiembre realizaremos nuestras 8ª jornadas SOCHITAB, esta vez en la modalidad virtual, y esperamos a todos ustedes que se inscriban y participen en ella. Tenemos este año por primera vez un simposio sobre psicoterapia en trastorno bipolar y trastorno unipolar, y un simposio donde van a participar pacientes y familiares del Círculo Polar en un simposio que hemos llamado Expertos por Experiencia. Como les decíamos, esta es nuestra sexta sesión del ciclo de psicoeducación de educación médica continua, y el doctor Tomas Hayek hoy día nos hablará sobre la diabetes mellitus y la salud cerebral en pacientes con trastornos bipolares. En realidad es un honor tener hoy día a Tomas Hayek con nosotros. Él es una persona muy generosa que aceptó participar en nuestro simposio de manera virtual, y de verdad Tomás es una persona digna de admiración. Creo que corresponde al prototipo del investigador riguroso en psiquiatría. Tomás estudió medicina en la Universidad Carlos en Praga, en la República Checa, y posteriormente hizo un PhD en neurociencias también en la Universidad Carlos en la República Checa. Él ha ganado numerosos premios, entre otros el premio de investigación clínica en la Universidad de Dalhousie, y también ganó el premio HAFLAC para los mejores estudiantes en investigación y en la Universidad Checa. Tomás ha hecho muchas investigaciones y sus áreas de interés varían desde los trastornos del ánimo, en particular los trastornos bipolares, la imagenología cerebral, estudios en litio y sobre todo los estudios de neuroimágenes, donde se muestran los efectos del litio, y también estudios con espectroscopía de resonancia nuclear magnética. Ha hecho un aporte muy importante también a través de la participación en el consorcio ENIGMA. ENIGMA es un acrónimo que quiere decir Enhanced Neuroimaging Genetics Meta-Análisis. Son grupos por patologías que estudian neuroimágenes cerebrales y donde participan alrededor de 70 centros. Y muchos de los estudios del grupo de trastorno bipolar han sido estudios donde Tomás ha participado y de lo cual vamos a preguntarle algo al final de esta exposición. También ha estudiado mucho en investigación con litio y el tema de hoy día es el impacto que tiene la diabetes mellitus en los pacientes con trastorno bipolar y cuán complejo es este aspecto que habitualmente es descuidado por los psiquiatras en nuestros pacientes bipolares. Así es que dejo con ustedes a Tomás. Tomás, voy a dejar de compartir mi pantalla. You can share yours.
Thank you so much, Jorge. It's a great pleasure. It's and my honor to be here. Thank you for the invitation. Now, if people are in a hurry, I can just give you a brief summary of my talk, which would be something like this. Oops. Hang on. Do not eat those desserts. They are bad for your brain. So that's the take-home message from this talk. But let me elaborate a little bit. I don't have any conflict of interest to disclose, and let me first put things in a bit of a perspective. So, as you know, our brain is the most complicated matter in the known universe. And if the brain was so simple that we could understand it, we would be so simple that we could not. So, while we may never be able to breach this philosophical boundary, the hope was that with the advent of brain imaging, we will be able to get really, really close to it. And I think that to some extent, this has happened. The brain imaging has really advanced our knowledge of the psychiatric disorders. However, as a clinician, I can clearly say that in terms of practical utility, brain imaging has over-promised and underperformed. In fact, brain imaging as such has very little role in the everyday practice of clinical psychiatry. And we can wonder about the reasons for that, which may include the fact that the brain is the most complicated matter and that the technology is still not up to par with it. But I think that to me, the main reason why brain imaging research has not contributed to clinical psychiatry is related to the fact that clinical psychiatry has not sufficiently contributed to clinical research. And by that, I mean clinical heterogeneity. As clinicians, we know very well that people with the same diagnosis may be very different in terms of their symptoms, in terms of their functioning, in terms of their clinical course, response to medications, comorbid conditions, what have you. No two people are really the same. Yet the brain imaging studies still act mostly on the assumption that there is such a thing as a prototypical bipolar patient whom you can compare with a prototypical control. So these studies typically ignore this vast heterogeneity and tend to oversimplify and lump everybody under the same in the same category. And until we have much more clinical information in the brain imaging studies, I think we won't be able to correctly interpret the phenomena that we observe through the lenses of MRI scanners. And let me give you some examples of that. So here is a meta-analysis of amygdala volumes we did some time ago. You can make the same arguments for essentially any other brain imaging modality or brain structure. What you can see here is marked heterogeneity of results. You can see that many studies did not find differences between the groups. The effect sizes cross the zero here. So these are studies that did not show significant differences. What's even more striking is that some studies found smaller amygdala volumes in patients than in controls, whereas other studies found larger amygdala volumes in patients than in controls. So this is what we would call a statistical heterogeneity, which I believe reflects the clinical heterogeneity. Now, if you simply add up these effect sizes, the negative ones cancel the positive ones, necessarily you end up with no overall difference. So if you simply ask yourselves, are there brain imaging or neurochemical changes in bipolar disorders? Based on this and many other meta-analyses, you would have to say, nope, there are none, because the meta-analysis shows no difference between the groups. And that's not a very satisfactory result. And it's not one that would even respect the individual studies that are included in the meta-analysis. It would seem to me much more interesting to ask ourselves, which clinical variables underlie the brain imaging changes in bipolar disorders? And why is it that some patients with bipolar disorder show smaller amygdala volumes, whereas others show larger amygdala volumes? So this also clearly indicates that, for example, the changes in the amygdala volumes can't be related to the diagnosis, because all of these people have the same diagnosis. So they have to be related to something else above and beyond the diagnosis itself. What could those factors be? Well, let's take a look at that briefly. So we know that there's certainly some genetic factors which may alter the brain structure and make people more likely, maybe in interaction with the environment, to express the phenotype that we call bipolar disorders. So there's some genetic factors which undermine some of the brain changes that we see. We also know that the repeated episodes of the illness are bad for the brain, that they leave a sort of scar, if you will, on the brains of our patients. People who've had more episodes, their brains would look much worse than people who had only a few episodes. Then there's the treatments, and we're hoping that treatments have beneficial effects on the brain, but that may not necessarily be the case. It seems that lithium does have neuroprotective effects, whereas, for example, anticonvulsants or antipsychotics may often be neurotoxic. And then we have the comorbid conditions. And we know that comorbidities are more of a rule than an exception in bipolar disorders. And I'm not talking only about psychiatric comorbidities. I'm also talking about medical ones. And these things would have their own signature, their own stamp that they leave on the brains of our patients. So in an extreme case, one can imagine that many of the brain changes in the brains of bipolar patients actually do not reflect the presence of bipolar disorders, but rather the presence of the comorbid conditions. So the comorbidities are particularly interesting, and they're particularly understudied when it comes to brain structure. Yet they could be really beneficial to our understanding of the illness and to clinical translation, because studying the comorbidities could help us identify preventable risk factors for brain changes in bipolar disorders. It could point towards mechanisms that underlie these changes, and it could also provide some new targets for treatment of these alterations. And so it's not surprising that a recent JAMA viewpoint said that the brain and neural network changes in diabetes and depression are the new frontier. I would very much agree with that. The presence or absence of comorbidities could also help us explain why brain changes are unevenly distributed among people with bipolar disorders. Why is it that some people show marked changes whereas others don't show those changes? And last but not least, the comorbid conditions could also help us understand why we see such an overlap in brain imaging findings between major psychoses. So if you look at the patterns of brain alterations that we see in bipolar disorders, and this is work from the Enigma study in about 6,000 people, and in people with schizophrenia, the patterns are remarkably similar. If you covered the titles, I couldn't tell them apart really, and nobody really could. It is basically the same regions are affected in both. And maybe the reasons why we see such similarities are related to the fact that bipolar disorders and schizophrenia share many of the comorbidities which affect the brain. And one such comorbidity, which is particularly relevant and which is known to affect the brain, is various metabolic alterations, and in particular, diabetes mellitus. Now, we know that diabetes is disproportionately frequent in bipolar disorders, that about twice as many bipolar patients have diabetes than people without diabetes do. And this is a meta-analysis which is based on studies which mostly did not actually measure glucose levels in the participants. They simply asked them about the history of diabetes. So this estimate is actually most likely a very low estimate, because we know that diabetes is very often underdiagnosed in people with bipolar disorders. And when you look at studies which actually did the blood tests, they show up to 3 times elevated risk of diabetes. We did something like that in our bipolar registry among 121 participants, and 13% of them knew that they had diabetes. Overall, 21 had diabetes when we did the blood sampling. So in 40% of cases, we as the psychiatrists were actually the first one to diagnose these people with diabetes. In addition, there were about a third of the people who also had pre-diabetes, and none of them knew about that. So if you sum it up, 53% of bipolar patients had pre-diabetes or diabetes, and most of them had no idea that they had these conditions. So this seems rather pessimistic, but it is in keeping with other similar studies. And this is a big problem. Obviously, the high rates of diabetes will impact the medical health of our patients. And that, I think, is well known. Before we get to that, you may be asking yourself, why is it that the diabetes is so rampant, so prevalent in bipolar disorders? And there can be many reasons for that on many levels. So we, for example, know that there's some genes that are shared between diabetes and bipolar disorders. There's many biological alterations that are shared between diabetes and bipolar disorders, including the HPA axis dysregulation, increased noradrenergic tone, and so on. We also know that, for example, early adversity is a strong risk factor for mood disorders as well as for diabetes. And last but not least, there's a large number of factors why bipolar disorders can cause diabetes through diabetogenic medications, through lifestyle, comorbid substance abuse, and through symptoms such as atypical symptoms of depression, for example. So there's very many links between these things. My sort of research aim is not really to disentangle which of these is most relevant. I'm looking at it more pragmatically. I'm thinking, well, regardless of what causes this, I want to know how the presence of diabetes affects my patients with bipolar disorders. And it affects them quite a lot. For example, we can't really have a discussion like this, but there's the question here that I would normally ask people in the audience is, what is the leading cause of mortality in bipolar patients? And I mean, it's quite obvious what the answer would be considering the topic of the presentation, but many people would be tempted to maybe say suicide, and that would not be wrong. Suicide shows the highest relative risk, but suicide is still quite a rare event. And by far, the majority of bipolar patients die from cardiovascular disease, which can be tracked directly to diabetes, obesity, and metabolic syndrome. So here you can see that the relative increase is highest for suicide, but actually in absolute numbers, most people die from cardiovascular disorders. It also seems that the combination of diabetes and bipolar disorder or major psychiatric disorders is particularly lethal and is more deadly than the mortality associated with each of those conditions combined. So there's a bit of an interaction, and we don't quite understand why that's the case. But this is well known and has been recognized for some time. There's even now a Lancet commission looking into this. So the medical impact of diabetes on psychiatric populations is now starting to receive sufficient attention. However, what is not being sufficiently recognized is that the presence of diabetes also affects the psychiatric morbidity. Studies by us and others have shown that bipolar patients with diabetes, their psychiatric illness tends to be worse in many ways. They would have more of a chronic course, they would have more rapid cycling, they would have more disability, they would have increased rates of suicide attempts and completed suicide as well. In addition, we recently showed that people with bipolar disorder who have insulin resistance, which is the precursor for diabetes, that those are the people who have impaired memory functioning relative to bipolar patients who don't have insulin resistance. So this may be one of the factors which determines why some people with bipolar disorder show marked cognitive deficits even outside of the episodes. And we know that these cognitive deficits are a very strong predictor of functioning and employment and things like that. So here we have a factor which may trickle down all the way to why people cannot really get gainfully employed. Now, interestingly, bipolar diabetes is also associated with poor response to psychiatric medications, in particular to lithium. In this study of ours, you can see that most of the lithium responders, those are the dark blue columns, were recruited from people who were euglycemic, whose glucose metabolism was intact. Whereas most people with type 2 diabetes or prediabetes had actually poor or no response to lithium. So you may be asking yourself, why is it that a illness of the pancreas, a prototypical peripheral disease, actually affects brain outcomes in such a pronounced way? And that actually is not that surprising, because we now know that brain is one of the target organs for diabetic end organ damage. Aside from the microangiopathy, retinopathy, nephropathy, peripheral arterial disease, and cardiovascular disease, brain is actually one of the targets for diabetic problems. And it's not really surprising, because brain really relies heavily on glucose. It represents 2% of total body mass, but consumes about 20% of energy. And glucose is the only source of energy for neurons. And while neurons do not need insulin to uptake glucose, they need insulin as a growth factor. So insulin serves a lot of roles in the brain development as well as in maintenance of brain health. And so it's not very surprising that diabetes is associated with brain structural alterations, that people with diabetes typically have hippocampal atrophy, and they also have frontal lobe atrophy. And in conjunction with this, these people typically have memory and executive dysfunction. And also, they're at a markedly increased risk for dementia. That was shown for the first time in the Rotterdam study, and since then has been shown in many large community-based studies. Diabetes would about double the risk of dementia later in life, and it is one of the strongest risk factors for dementia, and one of the few modifiable risk factors for dementia. Now, it was initially thought that this diabetic encephalopathy, or the reason why diabetes increases risk of dementia, is related to atherosclerosis. But it's not really the full story of that. The association between diabetes and brain impairment goes way beyond angiopathy. It's shown even when you control for the vascular risk factors, and some of the metabolic alterations, such as the glucose levels or glucosylated hemoglobin, are better predictors than the vascular risk factors of these changes. And it's found even in absence of cerebrovascular disease. So it's not really an issue with the plumbing. It's not really just a vascular thing. It's also found only in people without diabetes, who simply variations in blood sugar are associated with changes in brain structure. And it's also associated with insulin resistance, so not a fully developed diabetes. And insulin resistance is not particularly associated with atherosclerosis itself. So there's enough evidence now suggesting that this is not just a cerebrovascular issue or microangiopathy, that there's more to it. And what is that additional thing that's causing this? Well, diabetes is associated with, first of all, withdrawal of the neurotrophic factors, including the insulin. It's also associated with systemic inflammation. And we know that low-grade systemic inflammation is particularly bad for the brain. Diabetes is also a prototypical example of impaired energy metabolism and mitochondrial dysfunction, which is also very bad for the brain. And diabetes is associated with oxidative stress. All of these things lead to atrophy or death of neurons, lead to synaptic reorganization. They lead to electrophysiological impairments and changes, which may manifest as the cognitive changes and potentially dementia. Now, these things that I just told you about, they may ring a bell because Alzheimer's dementia is associated with exactly the same phenomena. And it is also sometimes called diabetes of the brain or type 3 diabetes. It is also the same things that you often hear mentioned in conjunction with affective disorders, which are sometimes called metabolic disorder type 2. There's many reasons why diabetes impacts the brain, regardless of vascular pathology. Now, unfortunately, the effects of diabetes and metabolic alterations on brain structure are markedly understudied in psychiatric disorders, despite the massive impact of these conditions on our patients. If you look at Medline for brain and diabetes, you see thousands of manuscripts. If you add bipolar disorders to it, you see maybe 10 or 12. And there would be reviews among that, and there would be papers that don't really deal with diabetes at all. So that doesn't really reflect the importance of these factors, and we need more research in this area. So the available evidence, most of the studies that I listed there would be studies looking at effects of obesity in bipolar disorders. And these studies show that similar to general population, obesity in bipolar disorders is negatively associated with brain structure, especially in temporal and frontal regions. This can be found already in first episode of mania, in young patients with bipolar disorders, or in those at genetic risk for bipolar disorder. Some studies have even also suggested an interaction between diabetes and or obesity and bipolar disorder in their effects on the brain. We were among the first to do studies specifically looking at effects of diabetes and prediabetes on brain structure in a series of studies that we ran here in Halifax, where we systematically collected fasting glucose, insulin levels, and structural MRI, as well as magnetic resonance spectroscopy in bipolar patients and controls. And this study is still ongoing. But what we found was very much in keeping with our a priori expectations. We saw that levels of N-acetyl aspartate, which is one of the main markers of neuronal health, were lower in bipolar patients with either diabetes or prediabetes, whereas patients with bipolar disorders who did not have diabetes, their N-acetyl aspartate was comparable to controls. And while we saw the largest decline in NAA in people with diabetes, even those with prediabetes already showed these changes and had lower levels of N-acetyl aspartate than the healthy controls or non-diabetic bipolar patients. So this did not take full diabetes to show these effects. They were evident already in the early stages of diabetes. interestingly, we saw that the N-acetyl aspartate levels were associated with creatine levels. These are creatine levels in the brain, and that creatine showed the same pattern of differences as the N-acetyl aspartate. So together, this suggests that what we are seeing is impaired energy metabolism, because N-acetyl aspartate is synthesized, requires a lot of energy to be synthesized, and creatine is one of the main energy compounds in the brain. So it seems that impaired energy metabolism is the culprit behind these changes. Even more importantly, these changes had a real-life impact. And we saw that both the N-acetyl aspartate and the creatine were associated with general functioning of our patients, which was lower in those with diabetes or insulin resistance relative to those without them. So this may have been the intermediate step between the brain changes and the real functioning. We saw very similar patterns when we looked at the hippocampal volume or whole brain structure, again, lower in those with diabetes or already pre-diabetes, whereas not altered in those without diabetes. And we also saw that the association between age and hippocampal volume, which is quite normal. As we age, the hippocampus gets smaller. But this association was much stronger in people who had diabetes, which again is in line with many of the studies showing sort of accelerated aging of the brain in people with diabetes. Now, how do we interpret these findings? What does it mean? Well, I don't want to jump into conclusion and say, well, we see that diabetes is doing this. Let's consider some other explanations. So, for example, we know that about 80% of diabetic patients are obese. So could it be that what we're seeing are effects of obesity rather than effects of diabetes? And that did not seem to be the case. When we controlled for obesity, the results remained essentially unchanged. Also, it didn't seem that this was a plumbing issue, because we, first of all, excluded people who had cerebrovascular disease. And we also looked at some measures of the microangiopathy, specifically the white matter hyperintensities. And we did not see differences between the groups in rates of white matter hyperintensities. Those are those tiny spots that you sometimes see on the MRI scans. So it didn't seem to be a vascular problem in our case. Then you may be asking yourself, well, maybe this has something to do with the medications. And so antipsychotics are diabetogenic, and they may be negatively associated with brain structure. Lithium has neuroprotective effects, but may be less effective in people with diabetes. So maybe what we're seeing is simply differences in treatment between these groups. And again, we tried to control for this as much as we could, and it did not explain the findings. They still held even when we accounted for the medications that people were taking. So, as my favorite philosopher of science, Sherlock Holmes, said, when you have eliminated all which is impossible, then whatever remains, however improbable, must be the truth. So it does seem most likely that what we are seeing is really association between diabetes or prediabetes and brain structure. Now, there's one important limitation that I need to mention. These initial studies were cross-sectional ones. So we don't know what comes first and what is the consequence, right? So it could be that diabetes is damaging the brain in bipolar disorders, but it could also be the other way around, that maybe the brain changes that are associated with bipolar disorders may make people maybe more impulsive, for example, or more reward-seeking, and these people may end up with a greater risk of obesity. So we cannot really differentiate between these two options from a cross-sectional study. And we are now running a prospective study to look into this. And I suspect it will be a combination of both directions, but we'll see. Now, this raises a myriad questions. And to me, the most important one is, okay, so if we assume that diabetes may contribute to brain changes in bipolar disorders, can these changes be reversed by treatment or prevention of diabetes? And there's some evidence suggesting that that might be the case. So this is an interesting study from Taiwan, where they found that diabetes was associated with increased risk of dementia, but intensive treatment of diabetes brought this risk back down to essentially population level. So that may be an indication that it is worthwhile treating these conditions, also not only to prevent stroke or myocardial infarction, but also to prevent dementia. In addition, there's even a controlled trial of this called the Accord Mind study, where they tested whether intensive glucose lowering regime, where they were trying to get the glycosylated hemoglobin in diabetic patients under 6, whether it was associated with any beneficial effects on brain structure and cognition. And they did see a slower decline in brain volumes, in cortical volumes, with the intensive treatment. And this slower decline was in the same regions which were associated with longer duration of diabetes. So they concluded that, yeah, maybe this treatment slowed down the expansion of the diabetes-related changes. At the same time, they did not see effect of this treatment on cognition. And overall, as you may recall, this very intense treatment was actually associated with increased mortality. So it definitely is not something worth recommending, but more of a proof of principle that treating these changes is beneficial also for brain health. Now, we did a small study in mood disorders in people who had impaired executive functioning of liraglutide, which is a glucagon-like protein agonist. And we did see some effect of this treatment after 4 weeks on cognitive functioning and brain structure, but it was a small study. We need a larger trial. So to conclude, our results suggest that diabetes or even prediabetes are associated with impaired brain structure and chemistry in frontal lobes and temporal lobes. These changes may be related to impaired energy metabolism, and they may have real-life consequences in terms of the functioning. So this is very concerning because the rates of diabetes are very high, and the rates of undiagnosed diabetes are even higher in bipolar patients. At the same time, to look at the positive side of this, this could potentially be a modifiable risk factor for brain alterations and psychosocial outcomes in bipolar disorders. And maybe it could help us address some of the things that we are not very good at addressing with our psychiatric medications, such as the impairment in functioning and such as the residual symptoms cognitive symptoms during remission. So I will like to thank all my colleagues and collaborators, and I would like to thank you for your attention, and would be happy to take some questions.
Muchas gracias, Tomás, por tu presentación. De verdad que nos estimula a ser más cuidadosos con nuestros pacientes y investigar todas las comorbilidades médicas que ellos sufren. Hay un par de preguntas que las voy a hacer de inmediato. La doctora Fabiola Fernández pregunta: ¿cuál es el impacto del consumo del alcohol en personas con diabetes y trastornos del ánimo? ¿Y acaso hay diferencias en hombres y mujeres?
Yeah. Well, we have not specifically studied this. We have, that's one of our exclusion criteria is alcohol abuse. But that's one of the things that I think the evidence is quite clear, that this is not going to be helpful. This is going to be an additional factor in the equation, an additional thing that will further contribute to these alterations. So that's another modifiable thing that really needs to be taken into account, especially in people with diabetes. We know about the detrimental effects of alcohol use in diabetes as well as in bipolar disorders. So it's I think fair to say that this is one of the other things that need to be taken into account.
Ok. La otra pregunta de la doctora Fabiola Fernández dice, ¿acaso se han realizado estudios respecto a cambios en las estructuras cerebrales en pacientes con diabetes tipo 1, quienes viven más tiempo con la enfermedad?
Mm-hmm. Mm-hmm. Yes, they have, and they also show similar changes, but the mechanisms are probably quite different. In type 1 diabetes, the problem seems to be the hypoglycemias that are often induced by the treatment. So in type 1 diabetes, whether a patient will or will not have brain structural alterations primarily depends on the fact whether that person did or did not have hypoglycemia induced by the insulin treatment. So the mechanisms are different. In the type 2 diabetes, it's more about the insulin resistance and all the associated issues such as the inflammation, oxidative stress, and so on. In type 1 diabetes, it's really more about the hypoglycemia.
Voy a aprovecharme de tu buena voluntad, Tomás, y quiero que nos cuentes un poco de los hallazgos en el estudio del consorcio Enigma en cuanto a anormalidades de la corteza cerebral en pacientes con trastorno bipolar. Este estudio donde evaluaron 6.500 pacientes. Quizás podrías explicar un poco, digamos, el funcionamiento del consorcio Enigma.
Yeah, the Enigma is a fantastic collaboration among people who actually want to collaborate. So it's kind of a bottom-up process, and it's a very, very fun group to work with, as evidenced by the productivity and by the large sample sizes in those papers. And it is really a unique thing. And so the studies that we did will, I think, be becoming more and more interesting. The initial studies that Jorge mentioned were simply looking at differences between patients and controls. And these studies confirmed what we knew for the most part, and also showed the neuroprotective effects of lithium and showed that the antipsychotics may be negatively associated with brain structure. We then, the sort of next wave of studies now is trying to employ some machine learning techniques and see whether we can really use brain imaging to diagnose specific conditions. And that's, I think, where one of the main advantages of these studies lies, because the Enigma combines legacy data sets. So these are studies that were not coordinated to start with. These are studies that had different objectives. So they would have different information in them. And oftentimes, when we want to look across the studies, the things that we can get it's not really very deep phenotyping, right? Because the studies are so different. But at the same time, what we can get is a very broad representation of bipolar disorders from around the world. So I think the results from the Enigma are unique in the sense that they are highly generalizable. If you look at studies from, even our studies, from a tertiary care center, where you have a lot of selection criteria, you end up with a highly selected group where the results may not generalize to other people with the illness who are not as strongly selected. But within the Enigma, when you get to thousands of participants, the breadth of the clinical representation is huge. So it would include people with substance abuse, it would include people with bipolar NOS, bipolar 1, bipolar 2, maybe people with psychotic symptoms, without psychotic symptoms. All of that will be represented. So that's a fantastic thing, that these findings are going to be really generalizable to vast majority of patients out there. And we are now actually looking at the effects of obesity on brain structure in bipolar disorders. And I'm now finishing one manuscript that we're hoping to submit soon. And it's really interesting. There, it shows that, yes, again, obesity is associated with brain structure in bipolar disorders. But even more importantly, it shows that one of the most replicated findings in bipolar disorders, brain imaging findings, is larger ventricles. And it turns out that obesity actually is a significant contributor to larger ventricles in bipolar patients. That about 20% of that effect are caused by the obesity, not by bipolar disorder. And that has not been described before, and that kind of changes our view of things, because that was puzzling to me. Why do people with bipolar disorder have larger ventricles, which is also the most frequent finding in schizophrenia? And yet we know that in terms of the functioning and inter-episodic recovery, bipolar disorders are nowhere near schizophrenia. So that didn't make much sense to me, but this may shed some light into that. Both schizophrenia and bipolar disorders have high rates of obesity, and obesity significantly impacts the ventricular volume in these people. And that may be the reason why we see this overlap. So more on this will be coming soon, and I think these are really interesting studies from the Enigma Consortium.
Un punto importante, Tomás, es que los hallazgos en grandes grupos de pacientes bipolares hablan en general que un tercio de los pacientes tienen una capacidad cognitiva intacta, un tercio tiene un menoscabo cognitivo parcial y un tercio tiene un menoscabo cognitivo severo. Y claro, lo que encontramos habitualmente en el grupo o subgrupo de pacientes con menoscabo cognitivo severo son todas estas comorbilidades, ¿no es cierto? Obesidad,
Yes, yeah.
diabetes mellitus, abuso de alcohol y drogas, ¿no?
Right,
en fin.
right. Yeah, exactly. This is something that is quite obvious to clinicians, but something that the brain imaging community has a bit of a scotoma to. Yeah, they are very surprised by this, but a clinician such as you would say, yeah, well, that's exactly what we're seeing. Yeah, these are the people who will show the cognitive impairment, who will show the poor functioning, who will not recover well from the episodes, who will not have the full response to medications. That's quite, we've seen that time and time and again. And maybe that's kind of why that happens, is that all these comorbid conditions, not only the obesity, but the substance abuse and other things, that they make the brain sort of, they damage the brain further and contribute to these changes.
Ok. Hay otra pregunta acá. La doctora Zulema Sendón pregunta: ¿acaso hay alguna diferencia a remarcar en relación al trastorno bipolar tipo 1 y 2 con la diabetes mellitus? Si es que hay diferencia entre los dos subtipos de trastorno bipolar.
Not really. Doesn't seem to be a pronounced difference. This seems to be across the board of all bipolar patients. And it may be more pronounced in people who have atypical symptoms of depression, which is again quite logical. So hypersomnia, hyperphagia, it's not surprising that these people will have more obesity and more diabetes. But it's not really the subtype of bipolar disorder does not make much of a difference in this.
Ok. Yeah. Bueno, queremos agradecerte, Tomás, tu buena voluntad para estar con nosotros esta noche.
Thank you so much, Jorge. It was a pleasure anytime, and I hope everyone is fine and the COVID situation in Chile gets under control and life returns to normal. And my best wishes to all of you.